listening to you, and you kind of alluded to this too. You already alluded to the mind-body connection, and I'll even throw in the spiritual side of that too. But the patients that you're working with tend to be, today is probably the best they're going to be, unfortunately, and there's this constant decline. So how are you able to even measure some type of success, to see people, maybe how do you get them, I don't want to say better, but how do you mark or measure improvement overall, besides maybe not drooling or just not being somnolent all the time?
Yeah. So one thing is we look at their number of medications each patient is on, number of medication facilities on. We calculate how many patient in facility are on antidepressant, how many patients in facility are on antipsychotic, anti-anxiety, how many are receiving sedative hypnotics. We look at their percentage and we compare the percentage with our ideal number. So for us, for our standard, the ideal numbers is that the sedative hypnotic should not be more than 5% in a facility, that the antipsychotic should not be more than 10%. The patient should not be on an anti-anxiety for more than 15% of the time, 1-5. And really depression is very common. So we say up to 50% is appropriate usage. Above than that is inappropriate usage. So in that standards, if the numbers are falling in that threshold, that means we are keeping the psychiatric medication low as possible. Now, in terms of the outcome, yes, we're looking at whether patients are having falls, whether they're going to the hospital, whether they are requiring Baker Act. How is overall satisfaction of the facility? How happy are patients? Now, there is a more subjective component to that, but there's also some objective component, like their depression scales, their anxiety scales. There are cognitive scales that we administer time to time to assess their severity, and overall the severity is going down or not. Now, naturally, if patient is going to nursing home, it's expected that there will be some depression for some time, which will get better gradually as they start accepting of the situation. So some depression, some anxiety is expected. It's normal, natural, and it's fine as long as it's not impairing or causing too much distress. We really don't need to intervene. Just psychological support is good enough. But after that, if it's lingering or it's getting to the extent whether it is distressing, then we have to treat it. So the numbers of psychotropic medication in a facility is one good way to go, and the other is the scales and overall subjective reports. And traditionally, physicians have asked, how are you feeling? What symptoms you have? So more kind of subjective interviews are there. Our providers are seeing every patient at least once a month and just asking how things are going, and taking that subjective component, taking the objective component from the nursing report on how they're behaving, and taking even more objective component from the psychometric scales to see what their scores are. So that's what how
I was driving at that too. I wanted to see, okay, is there some observational component to some type of measure of physical improvement to, whether it's more ability to get up and walk, like you talked about, decreased fall risk, that type of thing. So
yeah, facilities are mandated. They're mandated to monitor these numbers, and they have to report to the federal authorities. So those numbers are already there, and we monitor them, and we see if they're going down or not.
What if you have a facility, assisted living, like Rhonda's parents, and they're active and they're living in the apartments or the condos? What are your non-pharmacological interventions, or what is your psychiatric care involved that's not drug related or just outcome? I mean, in other words, do you have plans for those folks too, or how does that work?
So assisted living do not have as a strong regulations as nursing homes, but I feel they should, because now we are seeing, because of this regulation, the psychiatric care in nursing homes have really enhanced and got better. With ALF, it is still okay, do your best and goodbye or good luck. So it really, there is no standardization in ALF yet, but I think that's coming. Sooner or later.
I was taking that to the other level, that with the, I know this is off tangent, but with what you said about the pandemic, of the adolescent care and the explosion of mental health over the next decade that's going to come from those folks. that's unrelated. I know that's just a thought I had in
No,
relation.
absolutely. But to come back to the initial question, how to manage ALF and even independent living. Independent living, I don't have answers because we're not providing services to them yet. We're mostly restricted until nursing home, assisted living, and then outpatient. So the independent living can come to outpatient, but we are not going there yet. With the assisted living, there are two types of patients. First is those who are cognitively intact and can participate in psychotherapy sessions and talk and can have insight and can develop coping skills. And those who are already developing dementia or losing the cognition and they're beyond the psychotherapy approach. So the first category of the patient can benefit from psychological support, providing just listening. There is no one to listen to their stories. They're lonely. Even providing a human being with open heart, non-judgmental attitude, listen to their stories and offer emotional support can take care of so many issues. They really don't need to go on medicine when somebody's there to listen to them, to relate to them, and develop some coping skills there. So that's one approach. The other is enhancing their participation in activities, enhancing their participation going out, um, being talking to them about diet and all those things. So that again comes to the counseling piece that can help. Now, if patients have developed dementia and they're beyond the psychotherapy approach, what we're doing is we're donating the supplies of sensory treatment to them. We give them aromatherapy diffuser, we give them tactile balls to squeeze when they have stress. We give them a dog that breathes on its own so they feel like there is a pet next to them sitting. We give them dolls. Some dementia patients regress and they feel like they have a baby, and we give them a doll, and that helps them. Music therapy. There are so many things that is a sensory treatment that can be given to them, and we are just donating these supplies to the facilities, and we encourage them to use it more and more. And some facilities use it very often, and we give them more supplies, and some facilities need more training on that. So that aspect is there to avoid the medicines. The other thing is that we are not shy of prescribing medicine. If they need it, we prescribe them, but then goal is to taper them off, wean them off of medicine so that they don't require a long-term medication. So those are a few approaches that we're taking to help them with their mental health needs while minimizing the medicines in ALF.